Welcome to the 2020 Public Health Law Virtual Summit. We have two presentations in this session, and each presentation will be followed by its own Q&A. Use the chat feature to submit your question, and if you encounter any technical difficulties during the summit, go to the navigation menu and select the Need Help button. Now I'll turn things over to our first speaker, Wendy Parmet.
Thank you so much, Charles. And I want to thank the Network for Public Health Law and all of the people behind this summit, which is so amazing, and my colleagues who I worked with in putting together the report, Assessing Legal Responses to COVID-19. I'm here today to talk about my personal contribution to that report and to talk about immigration law's adverse impact on COVID-19. To begin with, I should say that when I'm using the term immigration law, I'm using it very broadly to include not only the laws regarding entry and entitlement to stay in the United States and status, but also the laws that relate to the status and rights of non-citizens. And what I have found is that these laws, in a variety of different ways, have adversely affected our response to COVID-19, and they have done it through a variety of pathways. And through my talk, I'm going to talk about a couple of the different pathways that have played a role here. So first, immigration law has long in US history been used. Sorry, I'm a little technical difficulty, sorry. Immigration law, oh, my slides are going up and down, sorry folks. Immigration law has long been, don't know what's going on there. Immigration law has long been used as a public health intervention, as a set of laws that are used to protect the health of the people within the United States. On January 31st, as President Trump announced his so-called travel ban from China, interestingly, he used his immigration powers rather than his public health powers. And in the weeks that followed, as outbreaks began to occur in other parts of the world, in Europe, and then in Brazil and Iran, the president imposed additional travel bans, again, based on his immigration powers. Without getting into a discussion of the merits on travel bans in general, for present purposes, what's notable is that these bans were, as I said, imposed under the Immigration and Naturalization Act. And they did not actually ban travel on the basis of exposure, but on the basis of nationality and passport. They were in fact immigration bans, very similar to the president's earlier so-called Muslim ban. For public health purposes, what's important is that by basing the ban on passport status rather than exposure, the bans were incredibly leaky, allowing thousands of potential carriers to come into the United States, adding to the exposure. And equally, because the administration thought that viewed the threat through the guise of immigration law and nationalism, the bans were put in place without adequate regard to preventing the importation by US nationals. And perhaps even more importantly, without simultaneously taking steps to mitigate the disease within the US. In effect, the administration seemed to assume that it could use its immigration powers to build a virtual wall and keep out the disease. Or another way to think about it is they thought of the disease as belonging to the other non-US nationals, and if you could keep them out, we'd be safe. But of course, viruses don't care about nationality, and the immigration focus really, I think, let us down. The pandemic has also been used to achieve immigration goals that have little to do with the pandemic. For example, the administration has imposed a ban on visas that go through the end of the year. More problematically, CDC issued regulations that allow it to designate a country as having a communicable disease and blocking individuals from that country. CDC then went on to designate Mexico as such a country. And the Department of Homeland Security has used that designation in order to exclude and return people coming from Mexico and overriding asylum laws. So that's a way in which the pandemic became a pretext to achieve an immigration-related result. Immigration laws have also worked alongside structural racism and many other factors to leave non-citizen immigrants and their families and their communities especially vulnerable to COVID, which may help to explain why immigrant communities have been especially hard hit by the pandemic. And immigration law has done this in several different ways. And I'm just going to mention a few examples. For example, the 1996 Welfare Reform Act, also known as the Personal Responsibility and Work Opportunity Reconciliation Act, barred large numbers of non-citizens in various categories from accessing federally funded benefits, including Medicaid, CHIP, SNAP, and in addition, that act also enabled states to even be more restrictive in their benefits than the federal law requires. Then there's the public charge rule. In February, the administration, after getting the green light from the Supreme Court, went ahead and put into effect the so-called public charge rule. This rule, which applies to some classes, not all, of authorized non-citizens, creates, in a sense, adverse immigration consequences if they use public benefits, including Medicaid and SNAP. Although DHS issued guidance in March saying that use of Medicaid for COVID testing and treatment would not count as a public charge, I think there's no doubt that immigrants across the country have been terribly afraid of this rule. In fact, the fear is probably greater than many people are not actually subject to the rule, are afraid of it. And advocates are saying that immigrants are foregoing healthcare, COVID testing, because of fear of the public charge rule. The rule has been, there's a long procedural, sort of long litigation drama. It has been enjoined in some states, but it is effective in the country as a whole, although litigation is continuing. Immigrants also face labor vulnerabilities. So undocumented and unauthorized immigrants are not entitled to many of the employment benefits. They're often very afraid of reporting employers for unsafe workplaces. The support that Congress provided in response to the pandemic, most particularly the CARES Act, was limited to citizens and immigrants who file their taxes using Social Security numbers instead of taxpayer ID numbers. This again means that many non-citizens are really unable to access any compensation, any sick pay. They need to go to work even if they're not feeling well, even if they've been exposed to COVID, or even if they are afraid of unsafe work conditions. And of course, there's fear of deportation. Although ICE considers hospitals and clinics to be sensitive locations in which enforcement actions are not ordinarily carried out, clinicians keep reporting that non-citizens, particularly undocumented non-citizens, but also some authorized citizens who are in mixed status families, are afraid of getting health care because of fear of COVID. There's also been a lot of reports, these are anecdotal, but I think important nonetheless, that people are afraid of cooperating with contact tracing because afraid that this information will get to ICE They may not want to say that they have been exposed by or have exposed people who are undocumented. Sorry, I'm having all kinds of problems with my slides. In addition to these vulnerabilities inside communities, immigration law itself has been creating what one federal judge has called petri dishes of infection. So we have thousands of immigrants in immigration detention centers, and many immigrants are also being held in prisons around the country. There has been widespread reports of outbreaks in these detention centers among both detainees and employees. And I should say this is all before the exposés by the whistleblower in Georgia this week of the truly appalling conditions in a detention center in Georgia. The reports not specific to the pandemic about the forced sterilizations, truly shocking, but also the reports from the whistleblower of lack of adequate care for people experiencing COVID. There have been really hundreds of federal cases. Some detainees have won, but the overall conditions continue to go on. And also, and I think truly astonishingly, throughout the pandemic, the Department of Homeland Security has continued to deport people, even immigrants who are infected with COVID. And so that our country has really been exporting the virus. While we're trying to build these virtual walls and keeping out others, we have been exporting the virus to countries that have fewer resources to deal with the pandemic than does the United States. So the report has a lot of recommendations, just going to mention a few. It's important to note that almost all of our recommendations for the federal government are really to the administration. These are steps that the executive branch can take relatively quickly. These do not require acts of Congress. First, travel bans should be based on epidemiological factors rather than nationality or immigration status. If we're going to use travel bans as a pandemic response, we really need to focus on the epidemiology and not the nationality. Relatedly, CDC should base its regulations and its designations of countries at risk based on epidemiology, not based on passport, and CDC's rules and regulations should not be used as an excuse to override asylum laws, and CDC really should not be a vehicle for non-public health related policies. ICE should make it absolutely clear and message it in multiple languages around the country that it will not conduct enforcement activities in healthcare facilities, and it will not rely or use in any way information that comes from the healthcare sector or from public health contact tracing. People need to feel comfortable going to healthcare facilities and cooperating with contact tracers. The public charge rule should be repealed or at least suspended throughout this pandemic. Again, people should not feel afraid of accessing healthcare or accessing other benefits that their families need to stay safe and healthy during this pandemic. ICE should really expand its depopulation of immigration detention facilities. All detainees need to have adequate access to health care, and no one should be deported while they are infected. The United States should not be exporting. And finally, there are some things that states can do. And most importantly, states can provide Medicaid and CHIP to all otherwise eligible non-citizens. So there are several federal laws, and we talk about this, that allow states to be more generous, and states really need to take advantage of this. And states should also use their own funds to provide coverage to fill the many gaps that exist in federal law. This is not the time to leave people without health insurance. And with that really quick survey, and again, apologies for the technical problem with one of the slides, I look forward to your questions. If there are any. Seems like maybe no questions.
There were a couple of comments about the reports of hysterectomies on women in the ICE facilities, which you mentioned. I think in the reports I read, those were without, obviously there's an issue of coercion, but that they also were without consent. How do you think to the healthcare that's available in these kind of detention situations?
So even, in my talk, I'm really focusing on COVID, but even before COVID, the healthcare in detention centers has been widely condemned. There have been lots of reports over the years of inadequate healthcare. This latest report is truly appalling because it speaks not only to the adequacy of the care, but really basic human rights of informed consent, and whether detainees were being subjected to, in a sense, forced sterilization, right? So it harkens back to some really troubling times and eugenics. And obviously this is a whistleblower complaint, so it hasn't been thoroughly vetted. And it doesn't seem as though the forced hysterectomies were directly related to the pandemic. But it's exceptionally troubling and yet not, completely surprising given what we've seen. Last year before the pandemic, there were several deaths of children from influenza in facilities. People will remember, of course, the horrific stories about children in cages and the Inspector General's report about the lack of just sort of basic care the kids were getting. So, this is all of a part of a much longer, very troubling story about denying the basic healthcare needs and human rights of both minor detainees and adults. So it's not surprising that we're seeing problems with the pandemic.
We've got another couple of questions. In terms of long-term provisions, how would you convey the benefit of providing Medicaid and CHIP to undocumented individuals to states?
Yeah, so great question. Even in the absence of a pandemic, we know that Medicaid and CHIP not only improve healthcare, but have spillover for the particular individuals, but have really positive spillover effects for their communities. When people are healthy, kids can learn in school, workers can be more effective, and it provides a source of funding, critical, right, to our safety net providers. So depriving large classes of people access to health insurance is deeply troubling, not only to these individuals, but to the broader community and to the healthcare system. And I just want to make 2 points about this. One is it's way too easy, and we hear this in current events, it's so easy to other, non-citizens, immigrants, them, not us. But in fact, our communities are not separated that way. Over about 25% of kids are in mixed status families. Our communities are mixed with people of all statuses. When we hurt them, we hurt us. Who is us, who is them? And so denying people access, even in the absence of a communicable disease or a pandemic, is deeply problematic. Obviously, in a pandemic, it's foolhardy, it's crazy, right? It's absolutely crazy to deny some people access to care, deny some people access to treatment and testing, and then because, they're going to spread the disease unwittingly, not because they are vectors of disease, and it's important to say that, but because we are all living together, and when you deny some people access to healthcare, you're hurting the greater community.
Great. There was a thank you for mentioning the mixed status families. Could you talk about how accessible emergency Medicaid is for COVID-19 testing and treatment for undocumented immigrants?
So emergency Medicaid is it's not really, I don't like using the term Medicaid, right? Because it's really not Medicaid. Medicaid is health insurance. And emergency Medicaid pays for emergencies, and COVID testing is being covered. What's important to note that emergency is construed very differently in different states. In many states, what is an emergency is really what's an emergency under the Emergency Medical Treatment and Active Labor Act. And it really needs to be like, you need emergency care. You need to be cared for before you're stabilized. And so emergency Medicaid is really not a substitute for health insurance, although the federal government has made access and provided more funding for COVID. And I will admit, I don't know the extent to which emergency Medicaid is paying for COVID treatment. But the federal government is covering COVID testing, but emergency Medicaid is not a substitute for Medicaid, is the point I want to reiterate right now.
Okay, what would you recommend to respond to the fear that is so pervasive in marginalized populations?
Well, the first thing is to change the causes of the fear, and that's what our recommendations go to. But in the absence of that, I do think it's really important for advocacy groups and lawyers and health centers to try to provide clear information. Because I do think that the fear is greater even than the bad reality. So, for example, people really need to understand that the public charge rule does not apply, to all the many groups the public charge rule does not apply to, that even when it applies, for example, the Medicaid provisions don't apply to children. We need to get the word out about the DHS guidance about the public charge rule, about use of Medicaid for COVID is not being applied. In fact, DHS, as in the same guidance, provides a provision, a pathway for people to explain why use of other benefits, if it's pandemic related, DHS will take that into account. We need to provide support for people to do that. And we really kind of need to sort of lower the temperature and let people know that during the pandemic, keeping healthy, getting the healthcare they need is really the most important imperative, and that these provisions, while troubling, are not as broad as many fear that they are. And even where they apply, they're not being used as much in the pandemic as people fear.
Thank you.
Okay.
Great, thank you, Wendy. And I think
Yeah.
from there, we are going to pass things off to Elizabeth for her presentation.
So thank you so much.
Okay, I'd like to first echo Wendy's thanks to everyone who's been involved in creating this report and also this conference. I'm here to talk about protecting the rights of people with disabilities during the pandemic. And this is a really meaningful time to talk about disability rights and disability justice because the ADA turns 30 in July. And the ADA is a landmark civil rights law. It established a clear national mandate for eliminating discrimination and ensuring that people with disabilities would have equal opportunities in all areas of American life. And the law has transformed the lives of millions of people, but changing attitudes remains a work in progress. The pandemic has underscored the importance of these critical protections in many different areas and the need to include people with disabilities in any equitable response to the pandemic. But I'd like to spend my time today to talk about protections in healthcare and employment. Oops. Yeah, my slides are not advancing here. Okay. Why is COVID-19 a disability justice issue? Well, first, along the themes that Wendy was discussing about othering people, people with disabilities are a large and growing population. According to a recent survey, 1 in 4 Americans reports living with 1 or more disabilities. That's about 61 million people. And those numbers are expected to grow as our population ages. So we're talking about a huge number of us, of our friends, of our neighbors. And of course, disability intersects with all other groups. So we really need to bring in the experiences of people with disabilities and understand those experiences if we want to address health disparities for other groups. People with disabilities are also bearing the brunt of the pandemic, and that's for a few different reasons. They have higher rates of underlying health conditions that put them at greater risks. I'll talk about that a bit later on. They're more likely to live in nursing homes, which account for over 40% of COVID deaths across the country. Tara Sklar's contribution is centered on quality and safety in long-term care facilities. They're also more likely to rely on direct care workers. That can make social distancing impossible, and many of those direct care workers still do not have personal protective equipment. And of course, the crisis also exacerbates serious pre-existing disparities in health and other social determinants of health that we heard about in the plenary. Now, just to name a few, as a group, people with disabilities experience lower rates of employment amongst job seekers, higher rates of poverty and food insecurity, problems finding safe, affordable, accessible housing, lower levels of education, and persistent disparities in health status and access to healthcare services. This is the legal framework that I'm using. The Americans with Disabilities Act has a very broad scope, as you can see. It expands the protection of an earlier law, the Rehabilitation Act, that prohibits discrimination in federal employment and in activities that receive federal financial assistance. The Rehabilitation Act was amended by Section 1557 of the ACA to provide additional protections in certain healthcare programs and services. And these laws are intentionally very broad. They work together, and the titles of the ADA work together. For example, Titles 2 and Titles 3 together require that state, local, and private business mask policies accommodate people with disabilities. Between actually Title 2, Title 3, the Rehabilitation Act, and the ACA, nearly all healthcare providers, programs, and settings are covered. Something that's different about civil rights laws for people with disabilities is they don't protect everyone. They only protect people who fall within the definition of disabled. And here on the slide, you see that definition, physical or mental impairment that substantially limits one or more major life activities. Congress amended the ADA in 2008 to clarify that this definition should be construed broadly. That means, for example, that term major life activities includes the operation of major bodily system and organs, including the immune system, normal cell growth, digestive, bowel, bladder, neurological, brain, respiratory, circulatory, endocrine, and reproductive functions, among others, are all covered. As a result, many of the health conditions that the CDC has recognized as putting individuals at greater risk of severe illness are considered disabilities. Lung disease, cancer, serious heart conditions, immune suppressing conditions, and diabetes. High blood pressure can also be considered an ADA disability because it impairs the cardiovascular or the circulatory system. And this is true even if it's mitigated or controlled by medication. I think although it's a little too early to tell, COVID-19 infection itself may well be considered a disability. At this point, at least as of March, the EEOC, the agency that enforces Title I of the ADA, said that it was unclear at this time whether COVID is or could be a disability, noting that the virus is very new and there's still much we don't know. But I think there's some strong arguments that it could be a disability. I'm happy to answer questions about that if you're curious. So let's move on to healthcare. The COVID-19 pandemic has really highlighted how important these legal protections are in healthcare. And I'll be brief because I'm following Lance Gable's excellent presentation in the last session about medical allocation policies. But just for those of you who weren't able to make that session, in response to the burdens that have been placed on the healthcare system or the anticipated burdens, states and healthcare facilities developed triage policies to determine how they would allocate healthcare resources if there weren't enough resources to treat everyone. And disability advocates and organizations raised serious concerns about the impact of these and other policies that exclude, disadvantage, or otherwise discriminate on the basis of disability. To date, disability advocates and organizations have filed over a dozen complaints about healthcare policies in different states that they allege violate the ADA and other laws. And of course, these barriers to care during a pandemic are especially harmful because people with disabilities are already at higher risk for COVID infection and serious disease because of underlying health conditions and pre-existing disparities in healthcare and other social determinants of health. Echoing some of the themes of our plenary, this isn't new. This idea that people with disabilities are often excluded or disadvantaged in healthcare, but advocates did succeed in making it more visible and the law responded. Here you see the image of a March 28, 2020 bulletin put out by OCR. They provided clear, explicit guidance about medical allocation and other policies that explicitly or implicitly exclude or disadvantage or otherwise discriminate on the basis of disability. In fact, they say that people should not be denied care based on stereotypes, assessments of quality of life, or judgments about a person's relative worth based on the presence or absence of disabilities or age. The bulletin also emphasizes the obligation under these laws to ensure effective communication and to make reasonable modifications to meet the needs of people with disabilities. OCR has also been quite active in resolving complaints regarding policies. To date, I believe they've resolved 7 of the 13 complaints that have been filed. For example, OCR resolved a complaint regarding Alabama's triage policy after the state removed a language that allegedly allowed for the denial of ventilator services based solely on the presence of intellectual disabilities. They've also addressed different kinds of policies. For example, a Connecticut hospital policy that prohibited all visitors because it denied people with disabilities reasonable access to trusted caregivers and support persons. So how would I assess the law's response here? Well, OCR's clear guidance and resolutions have been extremely important. A coalition of disability rights organizations have also provided additional guidance to states and healthcare institutions and healthcare providers about how they can make reasonable modifications to meet the needs of people with disabilities. As Lance pointed out in his presentation, the worst fears that our healthcare system would be overrun were not realized. But I think what these policies did reveal is deeply entrenched disability bias and discrimination. And this is coming on top of very clear evidence of widespread lack of knowledge about the ADA and non-compliance with the ADA in healthcare settings. We also lack data regarding COVID-19 testing, infections, and outcomes for people with disabilities. As with other disproportionately impacted groups, we need this data to understand and respond to the pandemic. Now I want to switch to employment protections. Title I of the ADA prohibits an employer from discriminating against a qualified individual. Qualified individual simply means someone who either with or without accommodations can perform the essential functions of the job, right? There are limits. For example, an employer doesn't have to make a reasonable accommodation. That would be an undue hardship. That generally means excessive difficulty or expense, not really applicable to remote work policies, but also if they represent a direct threat. And they limit an employer's ability to conduct medical exams and tests. So let me talk about that last one first. We probably all know that many employers, probably including our employers, have instituted health screening procedures. They're taking temperatures, they're asking questions about symptoms. Some are directly testing employees for COVID-19 infections. And this is a disability rights issue because these kind of checks could reveal disabilities and other health conditions that may or may not be tied onto COVID-19, right? An elevated temperature, for example, can signal a COVID-19 infection or stress or pregnancy or a heart condition, right? And many people with hidden disabilities choose not to disclose them in the workplace to avoid stereotyping, stigma, and discrimination. So the ADA regulates, right, how much information an employer can require. It really divides it into 3 different stages: before an offer, after an offer, and during employment. I'm going to focus on during employment because that's primarily what we see. An employer can require medical examinations and can ask disability-related questions if they're job-related and consistent with business necessity. An example of that would be if an employee represents a direct threat to workplace health and safety. That means a significant risk of substantial harm to the health or safety of others that can't be reduced by a reasonable accommodation. This is an intentionally very high standard to meet because it's intended to ensure that assessment of direct threat is based on assessment of the risk using the best available objective evidence and not just stereotypes or assumptions about disability. But in this guidance, which you see here, the EEOC has provided, they make clear that they consider COVID-19 to be a direct threat. Now, this guidance is incredibly helpful. It's proactive, it's regularly updated, it's in a very easy to read Q&A format. It's definitely raised awareness of the ADA's protections and provided really helpful guidance to employers and to employees. And in this Q&A recently updated, they made clear that the virus poses a direct threat to workplace safety. That means that the ADA will permit, under these circumstances, reliable and accurate testing measures, taking temperatures, asking about symptoms, testing for present infection. But it does not permit testing for antibodies, right? The evidence of past infection. That's because the CDC doesn't recommend it for workplace decisions until we know more about the meaning of the results. So the EEOC says it does not meet the job-related and consistent with business necessity standard. Of course, employers have to keep any information that they gather confidential. Other chapters and presenters are talking about that. So I'll move to remote work policies. Reasonable accommodations are just changes that allow people to actually perform their jobs safely and efficiently. And here are the limits, again, that we discussed. Undue hardship is not really relevant to remote work policies. Direct threat, however, could be. This means that an employer can require an employee who tested positive or has symptoms to stay home, but if they're still well enough to work, they have to consider a reasonable accommodation, like remote work. Employers also have to consider accommodating employees who have underlying health conditions that are disabilities that put them at increased risk. Now, the EEOC has recognized remote work as a reasonable accommodation since at least 2003 and probably earlier. But if you look back at the cases before COVID-19, many employers and courts were reluctant to allow remote work as a reasonable accommodation. They often argued that on-site presence was an essential function of the job that just couldn't be removed. But obviously, remote work has become a much more common practice during the pandemic. Expanded work policies are a huge benefit to many workers with disabilities. In fact, they've been asking for them for a long time, finally are able to get, at least for some jobs. And they benefit other kinds of workers as well. And there is evidence that employer attitudes toward remote work may be shifting. We'll see if that lasts. But there's also gaps, as you can see in the Chronicle of Higher Education Act. And there's a couple of different kinds of gaps. One is based on types of jobs. Many jobs simply can't be done remotely, so it wouldn't be a reasonable accommodation, right? Managers, professionals, administrative support workers, they're most likely to be able to work remotely. While employees in service, construction, transportation, production jobs are often unable to perform their jobs off-site. And a lot of those jobs that require on-site presence are actually workers who are providing essential services. That's an estimated 26% of workers. And Rukaya Yerbi is going to look at protections for workers providing essential services tomorrow. So one is the type of jobs. The second is the ADA's protections are based on class membership rather than vulnerability to COVID-19. The ADA does not require employers to provide accommodations for employees who are at increased risk of COVID-19 for a reason other than disability. For example, age alone, or what is called ordinary pregnancy. Right? It also doesn't require that employers accommodate non-disabled workers who are in close contact with someone who is at increased risk because of a disability, such as a child with an underlying medical condition. Right, so based on my assessment, here are my recommendations, right? I had many, but I'm just gonna highlight a couple of themes that run across my recommendations for federal, state, and local governments. The first is that we have powerful laws, right? And these laws can be amazing tools to promote the health and well-being of people with disabilities, especially during the pandemic. But they really require persistent enforcement to be effective. So some of my recommendations are to the enforcing agencies, OCR, the Department of Justice, the EEOC, to continue to explain how these laws remain enforced during the pandemic and how they apply to issues that are arising. Under enforcement of the ADA has been an enduring issue. So it really is a sign of progress that the EEOC and OCR are taking action to protect people with disabilities during the pandemic. I think that should continue, and I think that should expand. In particular, it would be helpful if the Department of Justice issued some guidance about how the ADA applies to public and private mask policies, there seemed to be lots of confusion, perhaps intentional confusion about that. My second theme is, at the same time, the continued existence of these kind of problems shows that education is critical. Finally, better disability data are absolutely necessary to inform policy and program development. Right? And we do have standards for collection of disability data that were developed under the Affordable Care Act. And I'm going to stop there.
So one question we have is, at some point you had talked about guidelines, and we were asked who was part of that coalition, who participated in developing those guidelines?
Oh, it was multiple different kinds of disability rights organizations, probably well over a dozen. All of those policies are very helpfully collected at the website of the Center for Public Representation. If you go to their website and then look at the medical rationing policies page, they've collected all of the complaints, all of the press releases, all of the responses by OCR, and they've also collected all of the guidance documents put out by the different enforcing agencies and by very large coalitions of disability rights organizations. So it's really an impressive and incredibly helpful resource.
That's great. If other people have questions, please put it in the chat function. So someone has asked, are employer accommodation requests related to COVID the same as any other employer-related accommodation request?
Yes, they are. The law is the same. So the same, flexible, interactive, personalized process that we would use to communicate between the employer and the employee is exactly the same. The standards of undue burden and qualification and direct threat are all the same. I think the real difference is the pandemic has exposed something that people with disabilities have known for a very long time. And that's that disability is very contextual. I think the perfect example of that is high blood pressure. It's an incredibly common condition. Many people have high blood pressure that's successfully treated with medication, and therefore they may not need accommodations in their everyday life. So they may never reveal that they have high blood pressure in the workplace because they simply don't need to. Now they may have different concerns because high blood pressure can be an underlying health condition that increases your risk of serious COVID-19 disease. So you may feel that now you need an accommodation to avoid infection in the workplace. So it may be a surprise to employers to find out just how many members of their workforce have some of these underlying conditions. And because the circumstances have changed, right? Now we're in a pandemic, suddenly people who perhaps never thought of themselves as disabled find that they do meet that definition. People who never thought that they needed reasonable accommodations find that they really do, right? And it really underscores that disability isn't an on-off switch. Right? Wendy kind of mentioned the us-them kind of idea. There is no us-them, right? It's actually all of us. And as the circumstances change, our vulnerabilities are revealed or changed. So although the law is the same, the circumstances are certainly making it look different. I think the other difference is people with disabilities have argued for a long time that work from home is a reasonable accommodation and that they can work effectively and efficiently at home. And there's been a lot of hostility toward that, at least in some sectors. Perhaps that's going to change now that working from home is far more widespread.
Great. Someone else asked, this is, I think it's probably a subject of a different panel, but maybe it's relevant, we can talk about it related to our particular topics about the effectiveness of CDC's eviction moratorium and protecting these populations with housing stability.
I can't speak directly to that because actually the rights of non-discrimination for people with disabilities are actually addressed under a different federal law, the Federal Housing Act, and other related laws. I will say that it's a double whammy for people with disabilities because there is already a challenge finding safe, affordable, accessible housing, right? Add on top of that economic devastation and widespread evictions, and it's really a catastrophe.
Great. I would just add, for immigrant communities or non-citizens more particularly undocumented, these vulnerabilities, these protections rather from CDC are probably of somewhat limited comfort right now. The protections don't particularly apply based on citizenship, but people who are very fearful of interacting with authorities right now just are not, many of them are not going to be comfortable relying on these. But I believe, and unfortunately I don't have the schedule in front of me, but that there is a presentation on housing where these issues will be gone into in greater depth.
I think that theme of fear is really important. As you were talking, Wendy, I was thinking of, study after study after study, and certainly anecdotal reports during COVID-19. People with disabilities are afraid to go to the hospital, right? Although these policies are being challenged and OCR is taking action, the fact that the policies exist, and that OCR needs to take action just underscores how their lives are devalued. And especially when coupled with restrictions on visitors, there's really a concern about what would happen and would they be cared for if they actually went to the hospital. And paralleling with some of the comments you raised in your presentation, the last thing we want during the pandemic is people being afraid to seek healthcare, but they do have very valid reasons for those apprehensions. So the more we can communicate, be really clear about directly addressing, help actually these states and institutions develop better policies, that's the way we can try to mitigate those fears.
I think that's so important. And what's so terrible about the moment we're in is that the people who are at greatest risk from the pandemic, these populations we've been talking about who face heightened vulnerabilities, are the ones who need healthcare the most. And yet they have the greatest reason to be afraid of seeking healthcare, right? And so it's just really sort of doubly compounding the risk and the vulnerability and, the tragedy of this moment.
And echoing some of the themes of the plenary, this is nothing new. It's interesting to me, and I'm sure it is to you, Wendy, and probably lots of folks who are participating. These are things that many different communities have known for a long time. But suddenly people outside the community, or more people outside the communities, are noticing these experiences. It's really exposing some of these equities perhaps to people who weren't as aware. Being afraid to seek medical attention because of disability bias and discrimination amongst people with disabilities, that's nothing new. It's just heightened with a life-threatening virus.
I want to just add in that all of this created a risk for a pandemic. That wasn't new. That was predictable, right? Some of us have been talking about it. It was an issue that was raised in the public charge litigation before the pandemic came, right? That this policy made the whole country more vulnerable. by terrorizing people not to get help about seeking health care. And that if there was a communicable disease pandemic, that's not good, right? So these problems are not new. They were known, they were predictable, or the way that they would be exacerbated in the midst of a pandemic was predictable and predicted. And that's, you know, what's really hard, right? We knew about all of this.
Great.
We probably have time for one more question, if anyone has.
So I don't see any more questions. I just want to thank our panelists today, Wendy and Elizabeth, for a great presentation. And thank you all for attending today's session. Just a quick note that you can take the evaluation for this session by going to your Pathable page, scrolling to the bottom, and then pressing the Take Survey link. And that's it. Thank you all for attending and have a great rest of your day.
Thank you.
Thank you, everyone.